You recording. Hello, everybody. Welcome to a special episode of the Brain Podcast. This is a bonus episode where I share my journey in hypertension. So I'm Dr. Shabnam Das Kar. I'm a functional medicine doctor and a brain health coach. And I am honored to have as my guest today, Madhur Kothare. So Madhur, you're going to introduce yourself now because it's like you have so many different hats that I don't want to jumble it up. So over to you, Madhur.
Well, I actually wanted to wish good morning to everyone, though I presume it's a little late in the night in Canada. So, hello everyone. Now, I am by background an engineer. I have studied at IIT Bombay Indian Institute of Technology, Mumbai, and that's for my undergrad. And graduate degree has been from Princeton University, which is in New Jersey, USA, but both in engineering field. After that, for last 30 years, I've been involved in healthcare industry, some way or the other related to medical stuff, out of which about 23 years or so, I've been in preventive health. And a little more than that, about 25 or 26 years, I've been also involved with CMEs, continuing medical education. So I have a good bit of understanding of the field, and you can say hodgepodge knowledge. I don't practice because I'm not a doctor, but I like to stay healthy. I like to advise people on being healthy. So I have my own health blog. I have my own video channel on health. And obviously, it's very interesting to learn from Dr. Shabnam, who has so much of experience in functional medicine. And hypertension is a very big issue facing most of the people that I meet. And so I'm really keen to understand. I presume Dr. Shabnam has been telling me that measuring blood pressure is the thing that people do and make judgments based on that. And today she's going to throw a lot of light on so much science that has gone beyond that. So over to you, Dr. Shabnam. I will not interject while you are doing a good part of your presentation, and I'll come in with a few questions when I don't understand something towards the end. Please.
Thank you, Madhur. That was wonderful. And so for many of you who don't know Madhur, many people think he's a doctor, and in some areas he has more knowledge than average doctors. And Madhur, you're probably not aware of this. My journey into nutritional medicine, actually early days, I used to listen to you talk about nutrition, and I thought, oh, this is interesting. An engineer is talking about nutrition. I mean, and I have no clue about nutrition because back then I wasn't educated in nutrition at all. Anyway, switching gears back to hypertension, Madhur, as you mentioned, and I think recently you had an article on LinkedIn also about hypertension. So hypertension is high blood pressure, and worldwide it's a very big problem. More than 1 billion people have high blood pressure, but more than 50% are not even diagnosed. And of those who are diagnosed, only a small percentage have it under control. Now, one of the challenges is a lot of high blood pressure or hypertension doesn't have any symptoms. But sometimes, recently there was one paper from Europe where they said that when they looked at women, some of the symptoms were similar to menopausal symptoms. It was like body ache, headache, sometimes mild chest pain, but they didn't, they didn't think it was because of hypertension. But once blood pressure came back to normal, with treatment, some of these symptoms went away. So that was very interesting because we always talk about hypertension not having any symptoms. And for some people, the only time it is detected is when they go to a doctor's clinic and they get the blood pressure checked and they find out, oh, you have hypertension. Or worst case scenario, they might have a stroke, heaven forbid. And that is when they find out. So going back to hypertension and why I'm interested in it now, I've had hypertension for many years. And my mother's side of the family, everyone died of stroke, and all of them had hypertension, and all of them had young hypertension. I think one of my uncles, and back in those days, they probably didn't have a lot of, I haven't even met him. So he passed away before I was born. And he was probably in his 30s. And from what they described, it seemed like it was a stroke. My mother had a stroke, her sisters had strokes, her brother had strokes, and all of them died from stroke. So obviously my family history is very significant. But then again, Madhur, we have talked about this. My genes will not decide my destiny. But I thought I need to get a little more, careful about what my blood pressure is doing, because I talk about brain health and how optimal blood pressure, optimal blood glucose, and low levels of inflammation are the three foundations of good brain health. And, everyone I meet, people are more afraid of dementia than of cancer or any other disease, I think. And having optimal blood pressure is, of course, one of the primary things. So going back to my journey, again, the guidelines for hypertension management nowadays says that we need to measure blood pressure outside the office. So this means office meaning the doctor's clinic. So out of office blood pressure measurement is the guideline recommended way to diagnose hypertension. But most of the time, what happens is people go to the doctor, they find sometimes it's a high reading, sometimes it's a normal reading. And if it's a high reading, the patient may say, Doctor, I came like I was rushed and I was stressed out and there was terrible traffic. Maybe this is not correct. And the doctor also says, yeah, maybe it's not correct. You go home and check. So people have blood pressure monitors at home, and there are very good clinically validated ones available. But I realized that I wasn't measuring my blood pressure as often as I should have. So I would tell my patients, okay, you need to measure in the morning, afternoon, night. But I wasn't doing it myself. And I thought, oh, this is irksome because I have to sit still for some time, no tea, no coffee for half an hour, no talking while I'm waiting. So after that, I need to take 3 readings as average of all the three. Then, do I have it on an app? Or so it is not a good user experience, bottom line. And for my patients, it was even worse. I'd send them reminders. I tried to automate the reminders so that, but no one sent me the data. At the most, I would be, happy if they sent me 7 numbers in 1 week instead of, 28, which is what we would like. So I decided, no, there has to be a better way. And by that time, I of course got to know about the 24-hour ambulatory blood pressure test, which is one of the ways to measure out of office blood pressure. So you wear a cuff, like the usual cuff, and there's a device you carry it across. And that cuff is set to inflate every 20 minutes to half an hour throughout the 24 hours. So what happens is it also measures when you're asleep. Now, that one is kind of uncomfortable at night because, you can imagine a cuff inflating, deflating at night. I didn't get good sleep. I know that. So it was not the usual conditions. But anyway, this was a few years ago and this was here, and the doctor said, oh, your blood pressure is fine. But I realized it wasn't fine, and I'll come to that. So I said, okay, blood pressure is fine. I'm okay. Then, fast forward many years. So I was on medication, and I'm, of course, 110% diligent about my medications. But when I had COVID, I had COVID and I got the vaccine on the same day. So I don't know which one raised my blood pressure. But after that, I realized that, and again, I can't say it was because of COVID or the vaccine. It could have been incidental also. But then my blood pressure was up. So I said, no, I have to get something to do something about it. So by that time, I'm like always looking out for easier way to check blood pressure. So I got to know about this device called Aktiia, which this is a company out of Switzerland, and they don't have services in Canada yet, nor in India. So this is the device. And again, this is not the strap. It comes with a nice strap, which is irritated my skin. So I made one with elastic and Velcro. So by the time they launch, I think all over the world, they'll come with different straps. So I got it. So first I reached out to the company and I said, I live in Canada. Can I use your device if I manage to get it through somebody? They said, yeah, but we won't be able to provide you with, replacement if something is not working. I said, yeah, I accept that. So I checked whether the app worked here. Then I got it through a cousin of mine who was visiting India. I was visiting India. So a very long-winded way. But I decided I'm going to get my blood pressure measured regularly. So I got the device and I started wearing it. In one day, Madhur, I knew that my blood pressure is not in range. So I'll just start sharing my screen. And if you have any question, go ahead while I start this.
You are saying that you were taking medications all along and you thought that your blood pressure is in control. but when you had this device on, you realize that it is not in control. Is that what you're saying? Am I getting it right?
Yes, you got that right. The thing is, I realized that after the COVID and the vaccine, that when I measured once or twice at home, it was 130, 80, 130, 85. So I said, no, this is not what I want. I want it lower. But where my blood pressure was exactly, I didn't know. Like I said, I was not checking my blood pressure 3 times in a day because it is irksome. So this is the device. And again, Aktiia does not pay me or Madhur to talk about the device, but I'm just sharing what I did. And it's a very small thing. As you can see, it's very small, and but the strap was, this particular material didn't agree with my skin, so I was getting a lot of itchiness. So that was the reason I couldn't wear continuously, though I would have liked to wear it. And like I said, so one of the most important parameters we get to know from 24-hour blood pressure test is you can see there are 13 different things. Now, 13 different things may not be important for everyone, but very often, I'll have my patients tell me, doctor, my blood pressure is normal. I said, what is your definition of normal? Because your definition of normal may not be mine. So let's get a 24-hour ambulatory blood pressure test done. They said, no, why did my doctor not ask for it? I said, I don't know, but you have a family history of, and Madhur, all of us, of South Asian and origin, we either know or we have it in our family, someone at a very young age getting a heart attack or, having a angioplasty. That is fairly common. So South Asians get, all these conditions much earlier, and hypertension is one of the risk factors. So when I tell them, you have these high risk factors, your triglycerides are high, your inflammation levels are high, we need to get really, and you are just 42 years old. So we need to know what your blood pressure is. Most of the time, they are shocked to find out that their blood pressure is not where it should be. At times, it can go up really high. And they had no idea. They thought the blood pressure was fine. So while, systolic is the upper number, diastolic is the lower number, pulse pressure is the number, the difference between the two. And I won't go into great details in all of these. Heart rate, of course, you can get heart rate from your, Apple Watch or Fitbit or any other wearable as well. But this 24-hour BP is, sorry about that. So just as we have, continuous blood glucose monitoring, and we have something called time in range, I think times are coming where we will also look at blood pressure being in range. Now, these devices are new. So right now we don't have enough data on, should my blood pressure be between 120 and 80 for 90% of the day, or is it okay if it is not 90% but 85%? And is it okay if it goes up when I'm, working out or something like that, but it doesn't go up at night? Nighttime blood pressure, I will talk about. That is very important. But all these other, parameters of what should be the 24-hour range and what is the percentage for each person, we need a whole lot more data. And the other important thing is, as you know, Madhur, in science, a lot of what we decide and what we talk about is dependent on the baseline data. Now, baseline data, if we don't have on South Asians, on Indians living in India, or a lot of the Indian data comes from people who are of Indian origin, but they're living in North America or the UK or Canada. So we need, number one, we need a lot of data. There are 1.3 billion people in India, but so number one is we need data to know what are the numbers exactly right for, people of South Asian ancestry. Right now, we are going by what, the American Heart Association or all the major hypertension associations in the world say. And the other important area, Madhur, is, women and hypertension is also a very different area, again, understudied. So women basically need a lower threshold. And I won't go into that. I've written an article on it. So the other thing that was very exciting to me when I started reading all these papers, and I'm not a hypertension specialist. So for me, it was like digging and digging into a lot of the research. We talk about, salt sensitivity. So very often, I'm sure you've heard it also, that the moment someone is diagnosed with hypertension, they are told, you need to reduce your salt intake. Now, yes, very high salt intake is a very big problem for hypertension, for stomach cancer, whole bunch of stuff. But there is a lot of research which says that it's probably a U-shaped curve. So do we all need very low salt intake? And the challenge is, Madhur, it's very difficult to figure out, how much should your salt intake be? And some people have salt sensitive hypertension, some people don't have. And the traditional way of testing was the urine sodium test, which is not a routine test. I can't just go to a lab and say I want to get that done. That's more like a research tool. So I was very excited when a paper came out, and it's not a new paper, it's 2011, where they looked at 24-hour ambulatory blood pressure data and they classified it into, different categories where you could detect salt sensitivity from that. So I thought, okay, I need to find that out because I'm already taking very little salt. I don't eat processed food and things like that. But so that was another thing, another important information. My point is, all these information is available from a 24-hour ambulatory blood pressure test. And even if you don't have access to an Aktiia device, the 24-hour ambulatory blood pressure test, Madhur, is available anywhere in the world. In India, it does not even cost a lot, actually. So major hospitals have it, most cardiologists have it. A lot of doctors have the device, but they don't use it. So when I've asked cardiologists, why don't you use it more often? They say, oh, we only use it for, people with resistant hypertension, those whose blood pressure is not under control. I said, but then there is this huge missed opportunity. So many people roaming around thinking their blood pressure is fine when it is not. So one is, of course, the 24-hour blood pressure, and the next is the nighttime blood pressure. So if someone has, normal blood pressure rest of the day, but their blood pressure is high at night or it does not fall, both of these are, again, risk factors for heart disease, stroke, dementia, you name the whole lot. And again, without testing blood pressure at night, we won't know what the nighttime blood pressure is. Just by checking at home or checking at the doctor's clinic, this information is missing. And this is very important. Another important factor in, nighttime hypertension is sometimes we can, it's like a screening for obstructive sleep apnea. So if I go into that, it will take a long time, but it's important to remember if nighttime blood pressure is high, sleep apnea is something that needs to be ruled out. And that is a message to myself as well, because I'll come to that. So this is my data from Aktiia. As you can see, the report is December 19th to 25th. Now, I started using the device on 21st December, but, their reporting system is such where they use, this kind of a week. Now, the next thing that happened, first I thought, okay, 130/80, that sounds too high for me. Then I realized that the European Society of Hypertension has different cutoff values compared to the American Heart Association. But most importantly, I knew that this is not where I want my blood pressure to be. So these are the two green arrows. This is where I would like it to be, because like I said, in women, the blood pressure threshold needs to be, very likely it needs to be lower. And again, talk to your doctor. Same things don't apply to what Madhur and I are talking about here today is not medical advice. You need to talk to your doctor because there are multiple factors. Your age is one of the factors. If you have other conditions like heart disease, diabetes, kidney disease, so many factors decided. I'm talking about myself. So I want my blood pressure lower. And this is the reason my green arrows are between 110 and 70. And so this is where this thing, I said, oh, okay, Aktiia is from Switzerland. So obviously they use the European guidelines. So here is again, Madhur, this may seem like, oh, if they are in Europe, they're going to use that guideline. If they are in North America, they're going to use this guideline. And I don't know, in India, I think most of them follow the American guidelines. So the problem is, when someone is familiar with this and they're not familiar with this number, they'll think, 130/80 is fine. Recently, I was talking to somebody, the person said, 130/80 is okay. I said, no, not based on, what, you mentioned the sprint study in your article, a few days ago. No, not based on that. So they said, no, but why is Europe different? I said, I have not gone into the in-depth analysis of that data. Why is Europe different versus North America? But this is very important to know, because very often patients may be given the wrong information. I've had, patients with 140, 90, 42-year-old man telling me, my doctor says this is okay, just the blood pressure went up once in a while. I said, how do you know it's not going up at night? Anyway, so what happened is, this is actually data from an app called the BP Journal app. So I realized that Aktiia sends a PDF. So I requested if they could send me a CSV, because I tried to convert the PDF into CSV. And I don't know, Madhu, whether you've had that horribly frustrating experience where the data is like everywhere. So I reached out to this developer of this app. Now, this app is only on Android, and I was using it for my patients, for them to manually put in their blood pressure data. Because as you can see, this is very easy to explain to anyone. I mean, anyone will understand green, yellow, orange, red, like even if they don't know anything else. But this one follows the American Heart Association guidelines, not the European. So this was my first few days between December 22nd and 28th. As you can see, I had a lot of them in red and yellow. Then I reached out to my doctor. I said, this is not where I want my blood pressure to be. I need it to be lower. So I was taking olmesartan 40 milligram. So she added amlodipine 5 milligram. And after adding amlodipine, so this is January 27 to February 2nd. Why I'm highlighting the date is, sometimes these medications can take 4 to 6 weeks to act. So I added the amlodipine on 27th December. So it took 1 month for my blood pressure to come down. So the point is, someone starts a new medication and the blood pressure doesn't come down in 2 days. Give yourself some time, talk to your doctor. And like I said, we are not giving medical advice, but it's important to keep in mind how long a medication takes time to act completely. So yes, my goal is definitely to be all in the green, but at least between these two, with an additional medication, my blood pressure did come down. And I just love this, how it's easy to explain to somebody. Even if that person has just 7 readings, it's easier to explain. Now, nighttime hypertension. So the American Heart Association guideline says that nighttime blood pressure should be 110/65 or lower. So anything more than that is actually nocturnal hypertension. So normally our blood pressure is supposed to fall at night by 10 to 20%. If it doesn't fall, like I explained, it's a high risk for heart disease, stroke, dementia, everything you name. But there are many, I'm not going into these details, Madhur, because unless you have your own report in front of you, none of this is relevant. But I found out I was a non-dip. So my nighttime blood pressure did not fall 10 to 20%. So this is an average of, since December, I started using Aktiia. Now, December, obviously, this was a time when the second medication was not added. Slowly, you can see that now it is February. By the time it came to February, it was lower, but my nighttime blood pressure is still higher. It's not falling by 10 to 20%. And this is the last number I have, which is still not normal. It should be 110/65 or lower. So I still have a lot of work to do. And my heart rate is more than 70. So these were the criteria where they looked at, salt sensitivity. But I think mine is not so much salt sensitivity, because like I said, I eat very little salt. In fact, most of the time when I, go for meals to my relative's place, I find the salt too much. And all these processed food, anything, I find it too salty. It's like the chips are too salty. So I am not so majorly concerned about my personal salt intake, but I do have to focus on my heart rate. And this is the salt sensitivity I explained, your 24-hour heart rate. I talked about the less than 70 and being not.
What is this? What is this 24-hour heart rate? Is it the lowest value you have?
No, this is the average. As far as I know, this is the
But
average.
then if you exercise, then your heart rate
Yeah.
will go up. That average will go up, isn't it? Or
It
say
will
you
go.
are active in the house.
Yeah. So again, I'm not going into that today. Maybe someday we should go into it. Heart rate variability is a very important biomarker, and nowadays many devices can detect that. And you are a marathoner, so obviously, heart rate is something you're very familiar with. Maybe one day you'll tell us about it. So these
So
are
heart rate variability is very vital. If your heart rate is not variable, then that's actually bad.
Yeah,
The more the heart rate variability, it means that your body is able to adjust to the needs with time.
yeah,
Otherwise, it kind of indicates that your body is become insensitive to the demands. And
yeah,
so, more the heart rate variability, the better it is. It's
yeah,
better. It's considered better conditioning also.
yeah.
And there are devices which measure that, and they give lots of fabulous data, though the science is still evolving as to exactly how do you correlate, because people with relatively less conditioning also sometimes have better heart rate. It has to do more with how parasympathetic and sympathetic systems work with one another. And but that's probably going to be in the next 5 to 10 years a big thing in fitness and exercise and running probably.
Yeah, that's very interesting because heart rate variability is information we did not have access to earlier, other than probably in research, settings, because we didn't have these devices. These are like how many, last 10, 15 years, or even less actually. So more
Also, if you get heart rate variability, if you try to get with number of beats per minute and all, it becomes very difficult to know. So you
Mm,
have to go in the other order. You have to take the how many milliseconds is the typical distance between two heartbeats. And so you cannot measure your heartbeat for 1 minute, then measure
yeah,
another 1 minute, and then you see the difference. That's not what
no,
it's done. It'll be one heartbeat, second heartbeat, third heartbeat, fourth heartbeat. In that, how many, whatever, say, let's say your heartbeats are 60 heartbeats per minute, then it is 1 second, that is 1,000 milliseconds between each heartbeat. But first heartbeat to second heartbeat, you might have 996. The second one, you will have 1,023. So that variability is 26 milliseconds. Now, that is practically impossible to measure with any of the devices that we have. You cannot put a standard BP device
no.
or heart rate device and get that. Your Apple Watch also cannot, unless it has that setting. It's unless there is an app which actually can measure. It's very difficult. So that was my point here.
Yeah, that's very interesting because I have not done a deep dive into heart rate variability. And the next question will come if it is a patient who's talking to me about the heart rate variability, then they'll say, Doctor, how can I improve it? So then it goes into a different discussion. But recently, actually, one of my patients, she found her heart rate variable. So she was using an Aura ring, and she found it was not okay. And then, of course, like most of us, she started reading up, and I said I wouldn't have suspected that as well. So she read that she should be screened for sleep apnea. And I mean, women and sleep apnea is a different story. There's usually no snoring, or they don't stop breathing always. So she did a sleep study and she found she had moderate apnea. So this is like, it's sometimes it seems like magic, a simple device you wear, and there's so much of health information coming. And in the years ahead, of course, we're going to be able to interpret them a whole lot better. So going back to my slide, and Madhur, if you have any questions, feel free to ask. So this is the salt sensitivity part. So next, before I go on to the micronutrient testing, because I don't want to talk a lot in details about the micronutrient testing because it's not accessible from everywhere in the world. In India, I know you can't do it. This is a specialized testing which I did because, so Madhur, years ago when I was doing my cardiovascular disease modules as a part of my A4M fellowship, so our metabolic cardiology professor, Dr. Mark Houston, he did a lot of these lectures, and it was like, we say that it's like, drinking at the fire hose. And I am by background an OBGY, so cardiology is like far away from my area completely. And there I was listening to him talk about a very different way of managing hypertension. So he has published a paper, it was about 10 years ago. What he and his group did is they took a group of people, They put them on antihypertensives, and they also did this micronutrient testing. This is a specialized testing, not available in routine labs. And what they found is people with hypertension had higher micronutrient deficiencies than people who did not have hypertension. That was number one. Number two was when they were repleted with these nutrients, many of them, up to 62% of that particular study population, were able to either reduce their blood pressure medications, or a few of them could even get, stop their medications. But supplementation was not the only thing they did. They had good food, mostly I think it was a Mediterranean based diet. They had exercise coaches. They focused on sleep. So it was not just, okay, I'm not going to take antihypertensive medicines, I'll just take a bunch of supplements. No, that it's not as simple as that. But when I did my tests, some of the numbers were quite shocking, some of them were not. So one big thing was magnesium was quite low, and I take magnesium supplements, so I had to up my magnesium. CoQ10.
So, Doctor, one question is, you're saying this is a different set of tests, but many times we have this blood sodium and blood potassium. So, is this micronutrient test completely different when you talk about sodium, micronutrient, sodium as a micronutrient? Can you
Yeah.
just
So sodium, potassium, magnesium, these are routinely available in any labs, and those electrolyte balance is a very strictly maintained thing in the body. So, but just by checking blood sodium levels, we won't know whether a person has, sodium sensitive hypertension or not. But serum potassium is also extremely important, because when it comes to potassium, there is again a U-shaped curve, too high or too low. Both are not good enough. Magnesium, the problem is if we do a serum magnesium test, so that's the routine blood test that you can do anywhere in the world, that will not tell us about a requirement for magnesium, because most of the magnesium is not freely in the blood, it's mostly in the bones. So for magnesium, what we do is, because it's a supplement meaning we are supposed to get it from food, and if we can't get it from food, no one can get enough magnesium from food. Recently, I was talking to a medical student, niece of mine. She said, oh, there are so many high magnesium food. I said, yeah, tell me, spinach is supposed to be one of the highest sources. How many cups of spinach will you need to get 300 to 400 milligrams of magnesium a day? So she sat and calculated, and she said, oh, this is like, this is a lot. And she was looking at rice, not even spinach. So rice is,
also, the problem is, spinach as an example,
yeah,
might have a lot, but your body absorbs very little. I
yeah,
mean, typically, we know that iron, you talk to anybody, they say
yeah.
spinach is great for iron. But if you see, oh, body absorbs maybe 2 to 5% of it. So
Yeah, and it's not heme
spinach
iron.
has, so you're
Yeah.
right that you can say spinach has a lot of iron, but your body doesn't get much of it.
Oh. So going back to magnesium, so what we recommend usually is, because specialized testing is not available everywhere, not everyone wants to do them. So take magnesium supplements, start with 300 milligram at bedtime. And again, this is not medical advice. This is what I tell my patients. So, and then in the morning, increase by another 1 or 2 capsules to a point. If you have diarrhea, then you know that that's too much magnesium. Then you back off to the level where you don't have diarrhea. This is a very rough measure of knowing how much magnesium anyone needs. So that is one. And recently, I think, Madhur, you published an article on vitamin D3 K2. So K2 is something that is again not routinely measured. And I had stopped my K2 supplements because I got tired of, the number of pills I had to take. I got pill fatigue. I said, okay, I can stop the K2 for some time. But when my report showed K2 levels were low, obviously I went back to having them. So D3 K2, other, which was not a surprise, was CoQ10. So CoQ10 again is a mitochondrial nutrient. With age, CoQ10 levels go down. And I was taking one. Then there was some, I had to order it from New Zealand, and then it had to come in here, and they were charging extra for, it was a logistical challenge, nothing else. So I had stopped for more than a month, and I forgot about it. So obviously my numbers came low, and then seeing those numbers, I said, no, I have to add the CoQ10, because CoQ10, of course, has multiple benefits. Magnesium is like involved with 300, 400 different reactions in the body. So
This question on CoQ10, see, one of the problems with CoQ10, generally your body makes about 500 microgram, basically needs about 500 microgram and a day. And generally your body makes 98% of it. Food gives you only 2%. So whether your food is deficient or not deficient, it doesn't matter. You're going to get 2%. It's 98 maximum. Your body has to make 98. Now the problem is when we become older, say 50, 60, 70, the production of CoQ10 changes. Different organs will have different drop. Sometimes it drops by 30%. Sometimes some organs it drops by 40, 50%. Now, when you have 500 that was manufactured by your body, or say 490 micrograms was manufactured by your body, mathematically speaking, and it becomes half, now your body is making 295 micrograms, and you need another, your 245 micrograms. Now your body needs another 250 micrograms somehow, and it's deficient. Now food will not compensate. If you take supplements of CoQ, say 300 micrograms, your body will still absorb maybe 5 to 10% of it. It's very difficult to get unless you take it with fat and this and that, so many other things. Your absorption is going to be between 5 to 10%. So you will fall significantly short, even otherwise, with proper supplementation. And so it's not even a question of whether you should and hope that it is good enough. That's
So
Yeah.
Another important thing about CoQ10 is, number one, as you rightly pointed out, with age, CoQ10 levels go down. Number two, certain medications deplete CoQ10.
Yes.
Statin medications, this cholesterol lowering medications are a big one. Beta blockers, again, believe it or not, some people on beta blockers for hypertension. Well, that's probably not the best one. Again, talk to your doctor, find out why you're on the beta blocker. So that can deplete CoQ10. So what we say in the functional medicine world is, if you're over 50, take 100 milligram. If you are on beta blocker or statin, then you need to add 100 milligram per capsule. So it ends up becoming about 200 to 300 milligram. And the other challenge, Madhur, is, CoQ10 costs quite a bit also. So a lot of people find that cost a little restrictive. But we can't help it. These are these things are important. So obviously everyone has to decide what is like. For me, I decided, no, I have to be on CoQ10. So I am on it now. But yeah, it's a lot of pills. So recently a patient said, doctor, if I stop my blood pressure medicine, can I do with supplements? I said, I don't think so, because number one, they will not work as quickly and as well as medications. And how we look at it is, let us get your blood pressure down first with medication, because lifestyle changes take time. And supplementation also, in the study Dr. Houston did, it was 6 months by the time some of them could bring their medications down. And again, if you are not checking your blood pressure regularly, then definitely that is not a route I recommend to anyone. So I think
I consider supplements and medicines to be complementary to each other.
Yes.
And my typical view is, suppose I fall sick and I cannot cook food.
Yeah.
Then what do? Then I have to order it through one of those apps.
Yeah.
And some outside food comes to my home. So that food is substitute for my own cooking.
Yeah.
However, that's the way medicines are. Your body is not able to control blood pressure, so the medicine controls it to some extent.
Yeah.
However, getting outside food to you for rest of your life is not a good option. You eventually want to become all right and cook your own food. But you can't be all right overnight. You will need maybe a week. Let's assume it's a fracture. So it's going to take me 3 weeks to start cooking again. So for 3 weeks, I have to take outside food. And once I'm perfectly all right, then I can cease to have food from outside and have my own cooked food. So supplements kind of help your body to heal itself, to repair itself.
Yeah.
You cannot use them as a substitute for medicine. Medicine is supposed to give you the result today itself. The food I need tonight. And so both are needed. It's just that we are wrong in expecting one to do the job of the other.
Yeah.
And that's where the whole controversy has come. Even medical papers I see, they say this medicine gives better result than this supplement. I say you check the wrong thing.
Yeah.
The damn ill, I should have food from outside. The food from outside is not a substitute for my own cooking. The day I'm not well, I'm not well.
Yeah, so one very important thing is we cannot out supplement, poor lifestyle choices. If you're not eating well, not prioritizing sleep, not moving, those problems will not go away if I take 30 supplements. And the most important point is to get the blood pressure down, and very often it's a combination of medication as well as lifestyle. It's not either or. Medication alone will bring it down, but it does not take care of a lot of the other pathology. So anyway, I talked about sodium, potassium, magnesium. So what I did was I knew I wasn't getting enough potassium from food because I don't eat bananas and potato skins because of the carbohydrate intake. I'm insulin resistant. So I was definitely not going to get enough potassium. So I decided to add a potassium supplement. And the other thing I did is switch to a low sodium salt. So many years ago, I remember when I was in medical college in India, every hypertension patient we used to recommend a low sodium salt. But I don't know whether that practice still exists or not. So again, this is a very simple switch. You'll find, I'm sure you'll find low sodium salt. So part of the sodium is, substituted by potassium. That is easily available, I think, way easier anywhere in the world again. So this is my long list of supplements. And this is actually, Madhur, I know you take a lot of supplements, so you are not intimidated by this list. But sometimes some of our relatives will say, my God, you take so many pills. Then I have to explain to them, these are not your prescription pills. These are my supplements. This is what I cannot get from my food because of various reasons. And we'll go into that on some other day. For example, omega 3, even if I eat fatty fish every day, I will never get enough omega 3. And our bodies don't have the ability to make omega 3, but omega 3 is important for so many things in the body, from blood pressure, inflammation, triglycerides, whole, gazillions of them. So
That's
is
because
it
we have increased this. That's partly because we've increased so much of omega 6 in our
six?
diet, which was not there so many years back.
No.
I think 50 years back, we started getting scared about cholesterol and we said, drop this oil and this oil should not be eaten. And we started adding so called healthy oils, which are those omega 6 oils.
Yeah.
And it's not so maybe my grandfather didn't need as much omega 3 as I needed, but I do need because the oils that are used in my food are not necessarily healthy. And I cannot control all the foods that I have. Maybe something which I cook in my home, yes. But if I go to
Yeah.
my sister's house, I cannot say that you cook food in this particular oil, you cannot use your oil. Those kind of things are going to happen.
Yeah. So that is, all these industrial seed oils got all those heart healthy signs, I think. Okay. So this is again, this was December when I started off, 21st December, I put on the Aktiia bracelet. And this is the last data that I have. I don't have my May data because I don't have the CSV. But again, anyone can see this very easily. I was more here. I'm, here. Obviously, my goal is to get here, but I'm not there yet. So what are the things I need to do? One is obstructive sleep apnea, because at night my blood pressure does not fall. And so this could be one of the factors. And I'm resisting it. My doctor had given me a reference a long time ago because I don't want to find out I have it and then have to wear the CPAP. So that is something I have to deal with. That's more like my mindset thing rather than anything else. Weight loss, 100%. So weight loss, deep sleep, these are the two things which reduce blood pressure dramatically. And obviously, as long as the weight loss is maintained, the lower blood pressure will be maintained. But increasing muscle mass. Now, Madhur, you talk about longevity, and as you know, I mean, you are a marathoner, how important muscle mass is for long-term health. And again, South Asian muscles are not as the same quality as muscles in many of the people of European ancestry. And insulin resistance, the pre-diabetes, all those problems start in the muscle. So Indians have lesser muscle mass and more of fat percentage at the same body weight. Reducing sitting time, I realized that I spend a lot of time in the evening sitting, so I'm getting a stationary bike now to see what happens. repeat the micronutrient testing. I won't repeat it very soon. If I do repeat it, that'll probably be 6 months down the line, because like I said, nutrients do not suddenly rise very soon. We don't repeat these tests very often. Then I'm on olmesartan. Again, this is not medical advice, but I have to talk to my doctor to find out, because olmesartan has a shorter half-life and telmisartan has a longer half-life. Whether it will make any change to this thing, I don't know. So again, I'll have to switch, check my blood pressure, see whether there is any difference or not. So yes, it takes time and effort to do these things, because at this point in time, we don't have an easy tool, and that is my dream, Madhur. And one day, because of, AI and machine learning and everything, we should be able to put that data, 58-year-old South Asian woman, postmenopausal, on hormone therapy. This is her blood pressure. These are her other parameters. Which is the best antihypertensive for her? So we are not there yet today. It's still trial and error and check and, but I think we'll get there. So these are all the references, and my
I
slides.
have one comment on that reduced sitting time. Very
Yeah.
interesting you mentioned it. And I was also guilty of this particular part until I learned this maybe a couple of years back, 3 years back. I used to think that you need to do exercise. You
Mhm.
need to do exercise on a daily basis. And so what I would do is throughout the day I would work in
Yeah.
my office, and in the evening I would go out and do a long run. Maybe I'll run 5 kilometers, 10 kilometers, 15 kilometers, 20 kilometers. And so I would get those 10,000, 20,000
Yeah.
steps. And I would come back home and say, hey, 7,500 steps, I have done 3 times more. So I'm
Yeah.
phenomenally fit. Little later, I realized that exercise is a pathetic way of compensating or substituting activity. You actually need more of activity. So, what it means is if I have to do 10,000 steps, uh, instead of doing 2,000 steps in 23 hours and doing 8,000 steps in 1 hour, it's much better to do 600 steps, 600 steps, 400 steps throughout the day.
Yeah.
Little activity throughout the day is far better than a lot of activity at one go. Now, I can't tell people who are in the office to say, hey, leave your desk and do exercise every hour. But reducing sitting time is a indirect way of telling people that, hey, at least do some activity. Because if you reduce sitting time, what are you going to do? You're going to increase non-sitting time. What are you going to do by non-sitting time? You're going to get up. If you
Yeah.
get up and move around a little bit, you're doing some activity.
Yeah.
It's amazing that you don't, especially for diabetes, especially for maybe for weight loss also, uh, you don't need a huge amount of exercise. You just need a lot of little bit of activity all the time. And so that sentence look very simple, reduce sitting time, but there's profound amount of understanding of last 30 years in that single sentence that you mentioned.
Thank you, Madhur, for pointing that out, because as you rightly pointed out, and this is particularly a lot of people who are into fitness like you, they feel, okay, I have gone to the gym in the morning, then I can go back to the office and sit for 8 hours continuously. So multiple studies over the last many years have shown that, regardless of that exercise in the morning, it kind of negates that effect. If you come back home or in the office and you're sitting continuously. And the other thing in India is people spend a lot of time in cars, and sometimes they are not driving. And in the car, what are you going to do other than sit? Like you
You
can
can't get up also.
you can't get up. 2 hours in Mumbai traffic, like it's like, I mean, good that there's a lot of hybrid work going on now, which is reduces sitting time. Another way I use is I've gotten rid of the chair in my office. So for Zoom calls or consultations or anything, I don't sit anymore. And another recommendation I have for a lot of my patients find it very good is because a lot of work is done on the phone nowadays. So it's like I'm a tiny habits coach. So as soon as when I receive a phone call, I'm going to stand up and start walking. So obviously they'll need earphones and all that. So that is, again, a lot of people spend like gazillions of minutes on the phone. And the other thing, when you talked about diabetes, when do you sit? Sitting just after a meal is probably the worst possible thing people can do. So even studies have shown that even walking for 2 to 5 minutes, like I'm sure everyone can, I mean, anyone can do that. So walking for 2 to 5 minutes after a meal can bring down blood glucose levels. And this is also another technique I tell my patients with diabetes if they're using a CGM, that they've eaten something and they didn't want to eat really, but suddenly blood glucose are like in the 180s and 200s and all that. Is what should you do at that? I said, just go for a walk. It's also little relaxing because you're like,
Easy walk, not
yeah,
heavy sweating kind of walk.
no, it's
Sometimes people make that mistake. They
yeah,
want to do exercise. Means they say, "Hey, I'm going to go for a walk," so they just start sweating, and that's incorrect when you do it right after a meal. You just want movement so that your muscle
yeah,
start taking blood glucose,
blood
start
glucose,
soaking some blood
yeah,
glucose for their utility, and it brings it down.
yeah.
Actually, I have an interesting story about this sitting time thing. There's a health
Mhm.
tech company I was advising,
Mhm.
and they wanted to create a kind of a challenge for all their subscribers
Okay.
on how many steps a day you do. So the people who do highest in a day, say over a week. Now, what started happening was some people started gaming it by doing a lot of walk. On one day, they will walk 30,000 steps and
Mm.
all that, and the other days they don't do much. Now, that
No,
is also not good. So
no.
then they said, hey, we'll count steps 15,000 a day. More than that will not count. So you do it next day. That also didn't work. So they asked me, what's the ideal way to measure who's really active? They wanted to measure who's
Yeah.
really, who's doing the right things for their health.
Mm.
And I asked them what kind of data you get. So they said we get every 2 minutes. How many steps every 2 minutes? That's the
Mm.
data they get from Google, some health
Okay.
fitness app. So I told them instead of giving a lot of instead of taking total number of steps, you find out how many 2 minute slices they had throughout 24 hours
Yeah.
when they took at least one step. Now
Yeah.
automatically 7 hours of night will go away because you didn't take any step. Daytime, what did you do? Were you active? If you are slightly moving around, doing some work in your kitchen, it's probably better than going out and running 5 kilometers in the evening and sitting the whole day at your desk.
Yeah.
And so that worked very well because you cannot game it. Every 2 minutes,
Yeah.
I'm going to know whether you took a step or not. And give how many such 2 minute slices you had. 1 hour has 30. 24 hours should have maybe 720, out of which how many? 300, 200, 100. That is very enlightening. But maybe for the audience of this podcast you are doing, let people, maybe they may not be able to measure, but let them have this thinking that I will do a little bit of activity. I'll not focus on too much of exercise because many people say, oh, I have bad back, I can't do exercise,
Yeah.
or I'm too busy to do exercise. If they keep small activities happening,
Yeah.
I think that will be much better for them than just doing things at one go or in a gym or somewhere else. Yeah.
Yeah, Madhur, you brought up such an interesting topic. And so this thing about, 10,000 steps, is it 10,000? Is it 9,000? The thing is, sometimes when I look through patients, because I ask them, so you're wearing an Apple Watch, what did you learn from it? You're wearing a Fitbit, what did you learn? So what is your daily step count? Oh, I get 10,000 steps. I said, you get 10,000 steps, but I use a sitting score risk. So this is again an online calculator where they calculate the total number of sitting hours. I said, but 10,000 steps and high risk for sitting, the two are not matching. So when do you get your 10,000 steps? Like you said, they go for a run in the morning and they get most of their steps at that time. Then they're sitting in the office. So sitting score is high, but mentally they are thinking, I'm getting my 10,000 steps. I said, no, you have to focus on every hour, how much you're getting. If you can divide that and figure out, go for walking meetings or something like that. I mean, people spend so much time sitting, so walking meetings, and again in Mumbai, I don't know, maybe you can go to a mall or somewhere because I don't think you can walk around outside on a walking meeting. So thank you, Madhur. Thank you very much. I think this was a long and interesting conversation. Wonderful to have you here with me.
Thank you
And
so much, Dr. Shabnam, because I thought to be very honest, I was under the impression that blood pressure is blood pressure. You measure it. Yes, you don't measure it one time, you measure it 4 times a day, and then you figure out which is the lowest, that's your blood pressure, or something of that sort. Especially that your blood pressure dips at night, and since you're sleeping, you are not measuring your blood pressure. So whether it's dipping, whether it's not dipping, and it has a whole lot of risk consequences. I did not know that at all. So it's fantastic that I learned something new. At the same time, I expect that this becomes more mainstream knowledge. Even
mm,
doctors take this more seriously, and ambulatory blood pressure measurement becomes more routine kind of thing. I'm very sure, especially in India, I do not know about the rest of the world, but in India, it will save a lot of lives. I know personally so many of my friends who have this high blood pressure issue because most of them are now above 50. And unfortunately, most people think that, well, diabetes and high blood pressure is part of life, part
Yeah,
of old
that
age.
is the sad
You know,
thing.
it's considered part of aging.
Yeah.
It should not be. So I hope your message just goes out wide to a lot more people and they take some corrective action in their life. Definitely with the help of their doctors, cardiologists, especially because, as you said rightly, this is not a medical advice to anybody, but this is something to open your thinking a little better and so that you can discuss this better with your doctor. So that's from my
Yeah.
side, doctor. Thank you so much.
Thank you, Madhur. And in case anyone wants to reach out to you, what is the best way to get hold of you?
Is there a way to put a slide later on in this podcast? My
Uh,
email ID
I
is Madhur.
yeah, I can add this thing on the YouTube channel as well, and in the show notes, I'll add it to the show
Yeah,
notes.
yeah. So it's madhur.kothare@gmail.com. But you can check my name on Facebook or LinkedIn or Twitter. If you type my name, Madhur Kothare, and it'll. There are not too many people with that name in the world. I'm very sure it's not John Smith. It's not.
Okay.
Thank you so much.
Thank you, Madhur. This was awesome.